Hi, my name is Lydia Gowan. I'm an Arkansas State University family nurse practitioner student. This is my assessment video of the abdomen, male and female genital urinary exam and the rectal exam. Here's a 360-degree scan of my room. My patient will be lying here and my equipment is in my pocket. I perform hand hygiene and put on appropriate PPE and gloves. Hi, my name is Lydia Gowan. I am a nurse practitioner student and I will be doing your abdominal exam today. If I can get you to lie on the table with your arms at your side. Starting with the abdominal inspection, the abdomen is symmetrical. The contour is flat, the skin is free from any striae, scars, lesions. There's no visible peristalsis or aortic pulsation, and there's no distended veins. The umbilicus is midline. There's no distension or irritation noted. I'm going to auscultate the four quadrants of the abdomen. Vowel sounds are present in all four quadrants. All sounds are normal active in character and frequency. I am now going to percuss the liver, starting on the right mid-clavicular line, percussing downwards from under the right breast until dullness is heard. And now we're going to percuss upwards on the right mid-clavicular line from the level of the umbilicus until dullness is heard. I'm going to measure these 2 points now. His liver span is approximately 7 centimeters, which is within the normal limits of 6 to 12 centimeters. I'm going to percuss the spleen now on the left mid-axillary line. Take a deep breath. Okay. There's no splenic enlargement noted upon percussion. These sounds are tympanic. I am going to palpate all four quadrants of the abdomen now, starting with a soft pressure. Let me know if anything is tender. We are palpating for any tenderness, guarding, or superficial masses. Was any of that tender?
No.
Okay. We're going to do a deep palpitation now, depressing approximately 2 to 3 inches. Let me know if anything's tender. Again, we are palpating for any tenderness, guarding, or superficial masses. Any tenderness?
No.
Okay, and none are noted with deep palpitation. I'm now going to palpate the liver, putting my left hand posteriorly along the 11th and 12th ribs, pushing upwards slightly, and then with my right hand, I'm moving upwards towards the costal margin. Okay, now take a deep breath. All right, was that tender?
No.
All right. The liver edge is non-tender. There's no nodules palpated. There's no respiratory arrest or pain upon palpitation of the liver, so the Murphy sign is negative. I'm going to palpate the spleen now. Again, placing my hand on the posterior side and under the ribs, and using my other hand to palpate along the costal margin. Take a deep breath. Okay. Any tenderness?
No.
Okay. The spleen was not enlarged and there was no tenderness. I'm going to palpate bilaterally the kidneys now. Mid-clavicular line under the costal border. Any tenderness?
No.
Okay. The kidneys bilaterally are not enlarged and non-tender. I'm now going to test for appendicitis, assessing McBurney's point and the Robson sign. For McBurney's point, we are in the right lower quadrant, about 2 inches above the superior iliac spine. We're going to press downwards and release, assessing for any pain. Any pain?
No.
Okay. That was McBurney's point. Now for the Robson sign, we're on the left lower quadrant. We're going to depress and then assess for any pain that was felt on the right side from this palpitation. Okay? Any pain there? Roxing sign was negative as well. All right, now if I can get you to sit on the side of the table, we are going to now test for CBA tenderness using my non-dominant hand on the costovertebral angle, applying blunt percussion. Any tenderness?
No.
Any tenderness?
No.
Okay, bilaterally, CBA tenderness was negative. Thank you for your time. I'm going to excuse you now. The rest of this exam is verbalized only. We are going to perform hand hygiene and reapply PPE. For the male genital exam, the male is standing for this. And if the patient were an adolescent, I would first assess the Tanner staging. Then I would inspect the skin and hair distribution for any lesions, any rashes, infestations, or excoriation. I would then inspect the penis for any lesions or deformities. If the patient were uncircumcised, I would retract the prepuce to assess for phimosis. I would inspect the glands for any lesions, masses, excoriation, any discharge. I would separate the urethral meatus with my thumb and index finger to assess for any hypospadias, lesions, or discharge. I would then inspect the scrotum, assessing for any edema, lesions, masses, nodules. I would also, with that exam, observe the posterior surface of the scrotum for those same things. For the palpitation exam, for the male, I would palpate bilaterally the inguinal lymph nodes, noting their size, consistency, tenderness. Then I would palpate the penis, palpating for any tenderness, nodules, masses, consistency, induration. I would then palpate the scrotum, palpating for any edema, pain, tenderness, nodules, masses, induration, assessing the consistency. I would palpate each testes, noting their size, shape, consistency, contour, noting any nodules or masses with each of them. I would then locate these spermatic cords in the epididymis, noting any edema, any nodules, masses, consistency. I would then palpate the external inguinal rings and ask the patient to cough or bear down. I would then advance my finger slightly to assess the internal inguinal rings and have the patient cough or bear down. That would be the end of the exam. I would remove my PPE and perform hand hygiene. For the female genital exam, I'd perform hand hygiene and don an appropriate PPE. The patient would be placed in the lithotomy position. I'd begin by separating the labia and inspecting the mons pubis, labia majora, and the perineal area for any lesions, masses, ulcerations, any discharge, erythema. I would then inspect the labia minora, the clitoris, urethral meatus, and introitus for any lesions, masses, erythema, discharge. And then if there were any swelling noted there, I would palpate the Bartholin glands, only if they were swelling because they're not normally palpable unless swollen. For the bimanual exam, for the speculum exam, I would warm the speculum and inform the patient prior to insertion. Upon insertion, with insertion, I would insert with a slightly downward angle, applying downward pressure. And if the cervix were not visualized, I would readjust the speculum as needed. Once the cervix were in view, I would assess its color, assess for any erosion, any edema, discharge, any nodules or masses. I would also inspect the cervical os, noting its size, shape, any discharge or bleeding or lesions there. At this time, if any pap smear was indicated, I would collect endocervical and ectocervical specimens prior to any other diagnostic testing. After that, other diagnostic testings and wet prep specimens could be collected. With removing the speculum, I would loosen the screw while slowly removing the speculum while keeping the blades partially open to view the vaginal mucosa, assessing its color, any lesions, masses, nodules, any discharge or erythema, and then remove the speculum. For the bimanual exam, I would re-glove and lubricate my first 2 fingers. I would ask the patient to strain or bear down while inserting my fingers, and while inserting, I would assess for muscle tone, any nodularities, lesions or masses, and assess consistency. I would palpate the cervix, uterus, and adnexa bilaterally, assessing for shape, location, size, any nodularities, masses, consistency, and any tenderness noted anywhere in there. And then lastly, for the female exam, I would perform a rectovaginal exam. I would re-glove and re-lubricate my first 2 fingers. I would insert my index finger into the vagina and my middle finger into the rectum, assessing the rectovaginal septum, the uterus, pouch of Douglas, and the rectum for any lesions, tenderness, or edema. And that would be the end of the female exam. I would remove my PPE and perform hand hygiene. Now for the rectal exam, again, I would perform hand hygiene and don appropriate PPE. I would inform the patient of every step of the procedure prior to beginning. For the female patient, she can remain in the lithotomy position if she would like, or for males or females, they can be in the left lateral side-lying position with their upper leg pulled towards the chest, or they can stand at the edge of the table while leaning over the table. First, I would assess the sacrococcygeal area and the perianal area for any lesions, masses, rashes, edema, excoriation, and for any tufts of hair. I would then palpate the anus and ask the patient to strain while assessing for any lesions. I would then inform the patient prior to advancing and advance towards past the sphincter. And if the patient were to tense, I would wait for the sphincter to relax before advancing. With this movement, I am aiming towards the umbilicus. Once we are at the level of the sphincter, I am palpating the sphincter for induration, any nodularities, masses. I'm assessing consistency and sphincter tone. Then I would advance further towards the rectum. And once there, I would rotate my finger in a counterclockwise and a clockwise position, palpating bilaterally and posteriorly for any masses, nodules, lesions, tenderness, consistency, and then if the patient were male, I would also do a prostate exam at this time, palpating the prostate, assessing for any nodules, any masses, tenderness, consistency, induration, and also palpate the medial sulcus. Prior to that, I would tell the patient that they may feel the urge to urinate, and that's normal during the prostate exam. Upon removing my finger, I would assess any fecal matter for its color and consistency and perform a occult blood stool test if indicated. This concludes my exam. I would remove my PPE and perform hand hygiene. Thank you so much for your time.